we have to put the whole family on trial. We really have to clear that part of it. Now I said it's not headache, it's the headache in the pelvis which is causing problems for these patients. Day in, day out. It's not. They are suffering, they can't share, they can't talk, and it's a very kind of a, they get more introvert, and it happens mostly in the very working, very agile, and very successful ladies. Understand that's a bigger problem, and especially prime of the career and society and family. I do talk these difficult scenarios. This was the talk which I gave in New York, and that was the advanced innovative pain interventions, making difficult spine cases possible. So this is another kind of difficult scenario where we see the chronic pelvic pain, which is thought to be kind of a untreatable or 50% treatable. I'll give you a scenario today. For those 50%, there are another 50% which can be treated because we are not having the right diagnosis, so we are not able to help them out. Yes, it's as well as mankind is still mysterious, and what better than chronic pelvic pain is to talk about. Yes, we keep talking about globally the pain is a pandemic. And it's highly under-recognized, under-treated. We really should do something about it. Pelvis is a grand station, grand central station rather, where we all these organs meet. We are talking about GI, skeletal, muscular, vascular, urinary, neurovascular. And last 2 days we talked so much about other things. Let's talk something over and above, beyond, which is not really understood, well understood till now. Yes, there's a whole battery of the diagnosis. If you look at this, which has been very well elaborated, must have been for the last 2 days. But I'm going to go next to this. I'm not going to repeat these things again. Yes, it's a mixed pain at times. It's a nociceptive pain, which is an different neuroplastic pain and neuropathic pain. Sometimes it's a mixed pain scenario. So when you try to treat, understand. Now we don't know the somatic part, but sometimes with the neuropathic part of it as well, along with the psychiatric issues which they come up over a period of time. There is an anatomical basis of the pain which turns into neuropathic basis of pain. It is already recognized in the chronic pelvic pain, and there have been world over conferences about it. I have attended one in New York and New Zealand also, for the mental New Zealand in Australia, Sydney. And that was the CRPS sets in over a bit of time, and they call it CRPS of the abdominal pelvis. It's a very different entity, and it can be well managed, beyond conservative management, definitely. There's a Costco. The message to the all is treat for 1 month what you can. If you can't, take the help of the pain physicians, pain specialists. They can help such patients. And this is the CRPS, and they were sympathetic block works. And this is said you take over a period of time. This becomes more hypersensitivity is there, and they start getting aneurysm and hyperpathia. All those things are proper. It's not only the periphery. It is happening centrally also. It's fine at the brain level. And the good people are sitting here, radiologists, they really understand functional MRI picks up these days. What is initially physical becomes more a psychiatric issue. Please don't let it go that far. Treat it early. Because chronic pain is something which takes a toll on all aspects of life. And who better understand than you people? When patient keeps coming in crying, you saw that very beautiful skit which was done, and you understand how big was the problem. And we thank other Dr. Neeraj Jain for that too. So that's the, and there are reasons. I'm saying so it actually some patient has been helped by the rheumatologist. Where there is a patient needs more help, we can always go and try it. Yes, it's a multi-dimensional problem. So it's not only a physical problem. Treat all aspects of pain. All aspects of pain, and the treatment has to be multimodal, multi-speciality. But the message is, the one patient comes to this hall, chronic pelvic pain, should go to this hall, treat it. Please understand, we have so many specialists around, and we can really do an integrative approach so that patient doesn't have chronic pelvic pain once he leaves this hall. That's the whole message, whole thing I'm trying to do. Please. The insult is, the point is, we talk about insult, so many things. It is irrelevant. Treat the end result, which is the pain. And that's where the pain specialist really comes in. This is a beautiful slide. And this is true to life for such patients. I'm trying to tell you the psychological part of it. She says, I could no longer be the pain, the kind of excruciating pain I was in. I envy those with cancer, those who are allowed for appropriate pain treatment without question. She's been questioned again and again. She's having pain and she's been questioned again. So that's double pain. And we know, this always pains from me and all those things, they keep coming, and this day and night problem, by the way. And we need not feel sorry about this. The patient as well as us. We can do something about them, and that's where interventional pain medicine is coming in a big way, trying to help them. Please, we may treat the pathology or not. Whatsoever is the diagnosis, whatsoever is the lab test. But yes, there is one good treatment, and that is for pain, we can. And that is what matters to the patient for the matter. The patient doesn't know anything. For her, it's a pain. We have the future pyramid, we keep working on the line, always try accountability management. I say 1 month, anything. And thereafter is the time for interventional pain people. People keep medicating themselves. This is the biggest problem. And it's not only the SCIDs, it's the narcotics, other things. We keep doing government tonight. We keep going ultrasound and other things, and new morphine, Google patches and all. And they all keep taking toll on the part of the patient. Yes, this is the virtual reality which is coming in, which is really helping this patient psychologically. Now this is my talk starts from here, please understand the education part of it. They can't lose the battle in keeping so much ammunition with us. We have a supraarticular simplex block, we got a impairs block, we got a potential block, we got a spinal cord stimulators, DRH stimulation, and other things also. And this is what we say. I start with the hypogastric block, neoplasm of the pelvic cells, all you can do with pelvis, we can do it. Same we can do with ceiling plexus block, upper abdominal problem. The pelvis problem, the hypogastric plexus block, and impairs block. They work great for that patients. Never ever leave the patient in pain if there is a treatment available on part of the intervention. Number one, and let the pathology be treated by your own right, be it endometriosis or anything. These things can be all those things. Now this is hypogastric plexus block. We go just get here the F5S junction. We go paraspinally, we go to transdiscal also, and we can just give our medication. When I say diagnosis, always give a diagnostic block before you go for neolytic or RF. This is what is, I say, diagnostic first. These days we can do ultrasound guided. Beautiful technique. From posterior it is 6 to 8 inches. From anterior is 1 to 2 inches only. You can go anterior and do your hypogastric plexus block. Especially in thin patients, is very beautiful block. Hypogastric. And like you do pre-settling rectus, you can do it. Chemical pre-settling rectus. Just anterior ultrasound guided. 2 inches. Just 2 inches needle is good enough. And this is correlates sometimes the same way. Till you really decide what to do next. Now this is about a potential neuralgia. We keep doing potential block for all those deliveries and other things. This typically like this, we do pervaginal, we do posteriorly with the fluoro-guided. Lately we started with ultrasound guided. It's a very good tool now and it works great. Again diagnostic and therapeutic. You can do RF, you can do a heart block. Never ever do bilateral potential neurolysis because there's so much involved, sphincters are involved there. It's never ever. Yes, this is what is called a hybrid technique. We have a machine in our theatre, we have a fluoro also in our theatre. We use them very often in such patients. Piriformis is another problem. Why I'm trying to talk these things? Keep missing these things and they are treatable. This is why I'm talking. I'm trying to sensitize my friends group here that what all you can have. Piriformis pain, the potential pain, and you can do potential neuralgia, you can do work, you can do a steroid LA, you can do a GFC, PRP, you can do Botox also for that matter. And this is what the PRP kits look like. And another thing which is coming in, let's stop the lateral thinking. The GFC, the regenerative medicine is coming big way, exosomes are coming in a big way. Why can't we make use of these degenerative disorders if it is degenerative by any chance? And you can really help these patients. We are doing the carpal syndrome for that matter. Why can't we do potential neuralgia and entrapment? Sometimes we do even viscous supplements for those patients whether gliding is the problem, entrapment is there. Now this is what SI is. Must know, you have to rule out. Before you say it's a fibromyalgia, before you say it's not treatable, must look at the SI joint pain, must look at the piriformis, they are all treatable and this is how SI pain will look like. Be sensitized about it, we can do RF, we can go for years together and this is the caudal. Must, after doing caudal, try to do a, what do you see, the impairs block. Now impairs initially we do it for pocket annular tailbone pain. But in our perineum, pelvis, vestibule, vulvodynia, all those pains, anorectal pain, anodynia, this is a very good what you call block, which really helps. Diagnostic, straight away go for neurolysis. If there's no motor component in there, you can really knock it out with the RF or chemical neurolysis. And believe me, response is absolutely wonderful. Your patient will bless you like anything. And if need be, if patient keeps coming back again, you can do RF also. I've got a patient who got a sympathic sinusitis. If I have image, I can show you. And I do block these ladies coming to me these days, and I am doing the block. There's a Pandora box which is to do with musculoskeletal because spine pain can be referred to the pelvis. That's why we must rule out there could be something like this in this patient. Like this patient has got a particular syndrome, particular pain is going to be in the pelvis. So that can be well treated. Other patient is like we have a facial arthropathy. You can really treat these patients, be it ultrasound guided or fluoro guided, and the treatment is response is great. Another entity which is coming is the body pain, the bony pain, like osteoporotic patients. They have bony pain. We can go inside and do a nerve ablation, basic nerve ablation, BBNA, and it gives a great response. This is a very new modality of treatment that's coming. Or for the matter, severe osteoporosis with somewhere osteoporotic collapse, microfractures which are not shown radiologically. You can put in a needle, put in a cement. I've seen a lady 10 times she's come to me with a cementing. Not to forget, many times there will be mats there. Not to forget, because then the role comes is that you recognize where it is coming from, send to the oncologist first, and then you start doing the treatment, pain treatment. Obviously, they keep sending us back for the pain treatment. The pain may be coming from inside the myofascium. This is the ITP band here, and that is where ITP band, and this is the iliopsoas bursa. They give iliopsoas bursitis. Patient won't know. Patient comes to you with a pelvic pain, and they just put a needle there, treat iliopsoas bursitis. It gives a very good response. Same way the adapted tendinitis, same way people symptoms I told you, they respond. And this is another thing, pain may be coming from the hip or acetabular, or sometimes a patient has got a fracture insufficiency here or maybe mats there. The pain will be reflecting inside. You can do a hip block. There are 3 nerves, operator and femoral, and if you do block them, they again are pain free. Now this is another picture. You have so many neuralgias coming up in here. You know this map. Keep this map in your mind. Take a picture of this map in your mind and see where all its nerves may be coming from. You can do at least pain-free work for them. All these girls, you can do a pain-free work for them. This is for the picture, for the people who take pictures. Right. Now this is another thing. Iliac and epigastric, the nerves are coming right there. There is gentle femur also coming there. Sometimes there is other fracture which is coming, and they all are. This is the again another grand system of the nerves also, and so many nerves coming. Potential I told you earlier, and you can go and do a diagnostic and a radiofrequency and ablation and block. Easy. That's the whole point I'm trying to bring. Easy work and very good response. You just put a needle there and put a feed block there. Response is great. And lately, this new entry which is there, you put this tank cannula inside the peripheral stimulus which is coming. Beautiful technique. Beautiful thing which is coming. That's why these people are way ahead. And you put a needle on them, put enter, leave your tank there, and put the stimulator up, and pain is taken care of. 1 month of stimulation, 2 months of stimulation takes pain away for a few months to come. This is the beauty of this. Later tumors cutaneous, people know myalgia basilica, easily treatable. You can block it. It's a pure sensory nerve. We have come with the dorsal root ganglion stimulations, and they really are helpful. In the S2, S3, S4, you can do this. You can do integrate, grade, and on the way you can do direct foraminal also. Put in those DRG stimulator leads and do the D4. This is the female chronic pelvic pain protocol. You scrap this with the orthognathic flexi block. Go ahead, do it with the flexi block, depending on how it is responding. And you start thinking, going to put in a block, go back, and then again for male, same thing goes on for male pain, and then you go on for the high blocks. Hypogastric, spine stimulation trials, and then the spinal stimulations. And people who are not being helped by other methods, at least spinal stimulators and DRG stimulations there. And that is, there are few papers. Therapeutic value of spinal stimulation for radial ball syndrome. Same way, this is neuromodulation pelvic visceral pain. Review of literature. See the patient all targets. They are working well and they have been used, tried and tested, and they are already in market now. The integrate sacral nerve stimulations for via sacroiliitis. There's something like orgasmic prawn, something like that. For all those girls, they put a sacral lead also for orgasmic reasons. And this is permutation implantation. Sacral nerve stimulation to treat intractable neuropathic testicular pain. Sacral nerve stimulation to neuropathic lateral pain, like I told you after mastectomy. So we can't say no to these patients, or we can't help you. And we tell them, okay, you have to live with this. If we have these modalities with us, if we can do our needs for these patients, yes, we have to be patient centered. We have to be ethical. We have to be scientific. But it is effective. It works. Must be tried. Must be given them a chance. Now we know it at least, And I told you right in the beginning, nobody all lives in pain. Now we are trying to have a fat faces coming to happy faces. One of those people who come to me, let them live in peace. They are part of a very important integral part of family. It's our utmost duty to not just one person, the whole head of the family, to make them pain free. Teaching the best way learning. I keep doing workshops, and people know me, people who see me doing this, they keep coming for training. I thank my global family to help me out to do all this academic work. And thank you, my friends. Thank you once more for giving me time and sensitizing the all that we can do so much beyond what we already do. Thank you so much.